Welcome to tonight's webinar. We're very happy to have you. Um, Please feel free to drop where you're joining from tonight in the chat. We'd love to hear. Um, Dr. Lin and I are both in New York, and we'd love to hear where other people are joining from. And I am going to share my screen.
Recording in progress.
Oh, sorry about that. Great. So before we begin, a few quick housekeeping items. This session is being recorded and will be available within 24 hours. Please keep your microphones muted throughout the presentation, and you can submit questions anytime through the Q&A feature, and we will address them in our final segment. And we really appreciate that. Your participation helps us tailor this content to your needs. So I'm so excited to introduce you to Dr. Ning Lin. Dr. Lin is the Director of Cerebrovascular Neurosurgery and Co-Director of Stroke at New York Presbyterian Queens and Associate Professor of Neurological Surgery at Weill Cornell Medical College. Dr. Lin brings unique expertise combining both neurosurgical and endovascular techniques in treating cerebrovascular conditions. He specializes in AVMs, aneurysms, carotid stenosis, cavernous malformations, moya-moya disease, and other vascular diseases of the brain and spine. Dr. Lin performs surgeries at both New York Presbyterian Queens and Weill Cornell Medical Center, and he's fluent in both English and Mandarin Chinese. Dr. Lin, thank you so much for joining us tonight.
Rebecca, thank you so much for the kind introduction. So I am a neurosurgeon and specifically vascular endovascular neurosurgeon here at Weill Cornell. So I'm very happy to share some stories and experiences with everybody about AVM.
Fantastic. And sorry, we're having a little bit of a technical difficulty. But fantastic. And we are going to be launching a poll. So we would love to hear what brings you to tonight's webinar. So if you're experiencing unexplained neurological symptoms, if you've been diagnosed with an AVM, or you're supporting a loved one with an AVM, if you're a healthcare professional, if you're interested in brain health topics. Okay, fantastic. I'm seeing sort of a lot of across the board, and feel free to drop in the chat what other reasons you might have brought here tonight. I'm seeing one other. Um, yeah, it's really great to see this spread, and I'm our winner is I'm interested in brain health topics, which is fantastic, and yeah, really exciting. So go back to the main slide. It's great because Dr. Lin is going to dive right into AVMs and how we treat them. So over to you.
Okay, great. So again, welcome everybody. Um, so uh, we're talking about cerebral AVMs or cerebral arteriovenous malformations. So what are these lesions? So essentially, these are tangled clusters of abnormal blood vessels in the brain. These AVMs can sometimes also be found in the spine, and then they are also found in other parts of the body. But we're specifically talking about cerebral AVMs today. The AVMs create a direct connection between arteries and the veins, and that, as we see in future slides, become a problem and can be very dangerous. This direct connection between arteries and veins bypasses normal brain tissue or the capillaries, and this can really occur at any place in the brain. Just by volume, most of the AVMs occur in the so-called supratentorial space or the big brain, but we certainly have seen AVMs in the cerebellum or the small brain on the back side of the head or brainstem. Typically, AVMs are considered congenital, so they were present at birth, but usually the AVMs start causing trouble or causing symptoms in young adulthood. Next slide, please. So
Sorry about that. Oh my goodness. Here. Thank you.
no worries. Okay. Um, so we were just talking about why direct connection between arteries and veins is a problem. So that's because normally when the blood flows in our body, it goes from arteries into a network structure called capillaries and then go back to the veins. And if we remember back to our high school or college years, and the veins, the arteries and the veins will have the arterial blood and venous blood exchange in the heart, and then when the blood go back from the lung to the heart, it go back to the arteries. So that's how, in general, the body's circulation works. But in the AVM, there is a cluster of blood vessels that's called the AVM nidus that connects the artery directly to the veins. So it that bypasses the capillaries. The capillary serves as really two functions. One is that it really delivers oxygens and the nutrients to the brain tissue and the normal body tissue, and collect any sort of waste from the brain tissue back to the heart and to be exchanged out. So it's in this network where exchange of oxygen and nutrients happens. And secondly, the capillaries really serves as a resistor. So if you think about basic circuitry or physics, the pressure in the arterial blood flow is much higher than in the veins. But after a resistor of capillaries, the blood pressure sort of dissipates through the capillaries, and then when it comes to the veins, it's not that high of a blood pressure. So if we apply these two problems or these two principles in the AVM blood flow, where the arteries are connected to the veins directly, now there is no exchange of nutrients or oxygen within this nidus. So there is an area of the brain tissue that does not really have adequate supply of oxygen or nutrients. And then also there is a direct pressurization of the veins through this AVM nidus by the artery. And then the abnormal high pressure of artery is dissipated directly to the veins. Next slide, please. Um, so who has AVMs? AVMs are relatively rare, affecting less than 1% of the total population in the United States. Each year, approximately just a few, 1 to 2 new AVM new diagnosis per 100,000 populations in the US. As we said, AVMs are usually congenital lesions, so they are present at birth, but most are discovered between age 20 to 40s. It affects men and women equally, and really both people don't really know they had an AVM in their brain until the symptoms occur. Next slide, please. So what kind of symptoms do AVMs cause? The common symptoms of AVM include sudden severe onset of headaches, and these are usually different from the common variety of migraine headaches or tension headaches. It's usually much more severe, much more sudden onset, something that you have never experienced before. Seizures is a common presenting symptoms from the AVM. Other symptoms of AVM can very much mimic strokes. So weakness on one side of the body, vision changes, speech difficulties, balance problems, nausea, vomiting, or at the most severe, loss of consciousness. And as we mentioned, many AVMs cause no symptoms and are discovered incidentally. And this actually is becoming a more frequent ways of discovering AVM is when patients get a scan for other reasons. For example, somebody have an accident, some people may have cancer, some people may have other reasons to have a brain scan, and then now AVM is discovered. Next slide, please. So when do we consider AVMs dangerous? The most dangerous consequence of having an AVM in the brain is hemorrhage. So when a AVM causes bleeding in the brain, we call that rupture. And the bleeding by AVM is usually through a number of different mechanisms. As we mentioned, AVMs have very small abnormal tangled blood vessels. So these vessels are, by definition, more fragile than normal blood vessels. So if they break, they can cause bleeding in the brain. Another mechanism is that when the AVM causes the veins to dilate, there is pretty high pressure into the venous system, and then these veins can be dilated, and then they can also break, that cause different kind of hemorrhage. And then thirdly, AVM itself is what we call a driver of hemodynamic parameters. So it really increases the amount of blood flow through these blood vessels. So sometimes by having an AVM in the brain, it can induce aneurysm to form. So aneurysms are a different kind of blood vessel problem. They are bubbles outside of a blood vessel. And then if the blood vessel is subjected to high pressure in a chronic manner, such as the patient has an AVM or the patient has chronic hypertension, then they are more likely to form aneurysms. And these bubbles are also highly dangerous. They can cause bleeding themselves. So you can actually see all three of these features in this picture on the right-hand side. AVM, as we mentioned, is a cluster of abnormal blood vessels, and that were depicted by these cluster of red signals. And these bubbles within the AVM nidus or right next to the AVM, these are the so-called intranidal or paranidal aneurysms. And then the veins were depicted in the purple color, and they are much bigger than usual. So if we see in angiogram or in CTA or MRA that the veins are dilated or something we call ectasia, that's also a dangerous sign that the AVM could be dangerous or could be bleeding very soon. The annual risk of bleeding of AVM, depending on where the AVM is. If the AVM is in the supratentorial space, typically the number is maybe 1 to 2%. In the posterior facile brainstem, maybe a little bit higher to 2 to 4%. So in general, approximately 2 to 3% of bleeding risk per year. When we have AVM bleed in the brain, it can be very dangerous, it's life-threatening, and could cause permanent neurological damage. And these AVMs usually require emergency treatment to stop the area where it is bleeding from and then to prevent rebleeding. It goes without saying that these are medical emergencies, so 911 needs to be called and a patient needs to go to the emergency room immediately. Next paragraph, please. One word about AVM during pregnancy. It's an interesting topic, but it has been well documented that if a young female patient has a AVM in her brain, and this AVM is not treated and had not caused problem before, but this AVM during pregnancy has a higher chance of causing bleed than normal times. And that is because increased blood flow during pregnancy may increase the risk of hemorrhage, and this increased risk goes during the pregnancy and in the peripartum period. You can imagine that when there is fetus in the mother's body, the overall hemodynamic flow is increased, and there's more blood flow through the AVM, and therefore there is a higher chance of AVM rupture. The annual risk of a bleeding for a pregnant woman can be as high as 6 to 8%, and that is 2 to 3 times higher than a AVM otherwise. However, treatment of a ruptured AVM during pregnancy is very controversial because of the presence of the fetus. So it's very much a case-by-case basis. I quoted a couple of literature that discuss this particular topic. Next slide, please. So how do we diagnose AVM? There are many imaging modalities that can be utilized to diagnose AVMs. I listed a few common ones that we perform here at Weill Cornell Medicine and the Neuropresbyterian Hospital. CT scan is a very quick way to identify any intracranial abnormalities, especially bleeding. It's quick and good for detecting bleeding or any sort of traumatic injury, but it does not really give very high resolution of the soft tissue structure of the brain. And that is a specialty of the MRI. So MRI is it is a little bit more cumbersome. It takes much longer to do, but it does provide detailed information about brain tissue, blood vessels, and exactly where the AVM is. Cerebral angiography and the CT angiography are both specialty imaging modalities for blood vessels, and that's why they are called angiography. The difference of them is the CT angiography is a CT-based study. Basically, the patient goes through the CT scanner with a bolus of IV contrast administered to the patient. So it's still a very quick study, but this study is somewhat limited by the anatomy of the patient's brain and the blood vessels. It can be affected by artifact of the bone and other metal implants of the patient, and also it can sometimes be contaminated by the veins. Whereas cerebral angiography is really the gold standard to diagnose any blood vessel abnormalities in the brain. It is minimally invasive. It does require a small catheter to be placed either through the wrist or through the femoral artery at the groin area. And then this catheter is a thread into the neck area where contrast is administered and the X-ray images were taken to the brain. And then this is the best way to look at blood vessel structure and the blood vessel pathology. Whereas all four modalities are very useful to diagnose AVM, we typically use a couple of them in sequential manner. CT and CT are most frequently utilized in the urgent or emergent manner. Cerebral angiography is utilized both as a diagnostic tool and as a therapeutic tool, as we will discuss just in a little bit. MRI is usually reserved for patients who are more stabilized, and when we need to have very detailed anatomic structure imaging of the brain and identify where the AVM location is. That's when MRI is utilized. And these tests are mostly painless. The CTAs and CT and diagnostic cerebral angiographies require contrast dye, and they have their own different utilities, as we mentioned. Next slide, please. Yeah. So when do we need to consider AVM to be treated? So as we mentioned, AVMs are usually present at birth. They are usually congenital lesions. So a lot of times, if an AVM is incidentally found and not causing any symptoms, not all of them need to be treated. On the other hand, if the AVM presents with symptoms, especially if the AVM has caused hemorrhage, then they really need to be treated and treated right away. So for some AVMs, it may be appropriate to observe. So these AVMs have never bled, located in a high risk brain area. So treating these AVMs could be risky or could cause damage itself. Or the patient has significant medical conditions, and these patients usually we prefer not to touch the AVM if they are not causing trouble yet. And then sometimes very large or complex AVM are simply too risky to treat. If they are not causing any symptoms, they should usually be observed. On the other hand, if a AVM has bled before, is having other symptoms such as seizures or neurological deficits, located in a relatively safe brain location or usually superficial location, and then there's presence of angiographic risk factors such as a peroneal aneurysm, such as a venous ectasia, and these AVMs are usually recommended to be treated. Also, we talk about bleeding risk in a cumulative manner. So young patients, healthy patients, we consider their lifetime risk of having a bleeding from the AVM. They are usually under a bit of a higher lifetime risk. That's why we consider treatment for them more likely. Whereas if AVM is incidentally found in an elderly patient, usually their lifetime risk is much lower. Next slide, please. In terms of treatment options, there are three main treatment approaches: surgical resection, embolization, and the radiosurgery. I'll dive into each of them just a little bit. So surgical resection is probably easiest to understand. Basically, we need to surgically remove the AVM from the brain with microsurgical instruments and microsurgical techniques under a microscope. This is the most definitive way to treat AVM, although also most invasive. That's why when we discuss whether to observe or treating an AVM, we talk about the location of the AVM, the health status of the patient themselves, and also the angio architecture of the AVM. And that is to understand whether this AVM can be surgically resected safely or not. But surgical resection remains the most definitive way to treat the AVM. Once it's gone, because this is not cancer, it's not going to return. Embolization is a minimally invasive way to treat the AVM. Basically, as we mentioned for diagnostic cerebral angiography, where we use the catheter from either the femoral artery or the radial artery, go to the neck and inject contrast to see where the AVM is. We can go further to use microcatheters into the brain directly and inject embolic glues into the AVM vessel. And that basically block the AVM nidus and disrupt this connection between the artery and the veins. And that can also effectively treat this AVM. So as long as this connection between the artery and the veins is disrupted, as long as the nidus is filled with the embolic material, there is no blood going into this nidus, and then there's no future risk of bleeding. Embolization is very much limited on the angio architecture or how complex the AVM looks like. Frequently, not the entire AVM nidus can be embolized. So embolization and the surgical resection are a lot of times utilized together. That is, we first perform embolization to shut down the AVM as much and as safely as possible. And then we do surgery to remove the entire AVM. If the AVM is already 50-60% shut down, then the surgical risks become much less, and it's much safer to perform such resection. The third category is radiosurgery. Radiosurgery has been utilized for the last few decades. It's been proven a very effective way to treat AVM. You probably heard of the common technologies such as gamma knife or cyberknife. They are both effective technology in terms of radiosurgery for AVM. Basically, a focused amount of radiation is delivered to the AVM nidus, and the radiation itself causes hyalinization or shrinkage of the blood vessel within the AVM nidus, and over time, the AVM nidus actually goes away. The the biggest advantage of radiosurgery is that it is minimal invasive or non-invasive. It does not require opening the brain. So for a deep-lying AVM, for AVMs located in a very dangerous structure, a very eloquent area of the brain, radiosurgery is probably the preferred way to treat these AVM. The biggest downside for the radiosurgery, however, is it does not work right away. It takes approximately 2 to 3 years for the AVMs to shrink and to resolve after radiosurgery. So we typically reserve radiosurgery for AVMs that is non-ruptured and it is located in a highly eloquent or dangerous areas of the brain. In terms of recovery time, so as we mentioned, surgery is probably the most invasive. So after surgery, full recovery, I would say probably less than 3 to 6 months, but a few weeks to a couple of months is expected. Embolization is a minimal invasive technology. And then typically patients stay in hospital only for 1 to 2 days and then go back home and can return to activities within a couple of weeks. But this may require repeated procedure, and then this also may require surgery in conjunction. Radiosurgery, as we mentioned, is the least invasive technology. Patients usually do not need to stay in the hospital, can go home on the same day, and can resume their normal activities. Next slide, please. I just want to show a couple of cases that we have treated here at Cornell Neuropresbyterian recently. For example, this is a patient who had a ruptured AVM, presented with symptoms. He is 67 years of age. He presented with left-sided weakness and numbness. So the upper three pictures showed CT and CTA of this patient. You can see CT scan is very illustrative in terms of brain bleeding. So the patient has the brain bleeding on the right side of the brain in the frontal parietal area, actually in the parietal area, and the blood is very bright on the CT scan. And the next two panels demonstrated the tangle of the blood vessels right next to the bleed. So now we know there is the tangled blood vessel or the AVM that caused the hemorrhage. The lower three panels are from MRIs. Again, you can see that the MRI is able to identify the brain tissue and the brain anatomy in a much more detailed manner. So now we can see specifically that this AVM is located behind the motor cortex, is in an area of the brain that is quite superficial, and is also quite safe to perform any sort of surgery, and is not going to cause a permanent neurological deficit. Next slide, please. So this is a patient that we proceeded with a multi-staged embolization and also surgical resection. So the upper two panels were diagnostic cerebral angiographies. So you can see very clearly that tangled blood vessel in the parietal area or in the middle, posterior on the back part of the brain. And then you can see multiple feeders into this tangled blood vessel. And these feeders were sequentially shut down by embolization or by small embolic embolic glue injected of small microcatheters. And after embolization and surgical resection, the angiography demonstrated that there is no such tangle of the blood vessel, and then the AVM is gone. So this patient actually was able to return home after a couple of days. Next slide, please. And this is a picture of a much different kind of AVM. This is a very large, complex AVM that is located very deep inside of the brain. You can see from panel B and panel C, there are many large feeders into this AVM, and the AVM is not located superficially, but within deep inside of the brain. So this is not something that we considered operatable. So we treated this AVM with multi-staged embolization. Each embolization aimed to shut down a segment of this AVM through one particular feeder. And then we administer radiation to the rest of the AVM. And then the lower panel, J and K, demonstrated after 3 years of radiation, the AVM actually went away. Next slide, please. Um, so you, although AVM is a relatively rare occurrence here in the population, we here at Neuropresbyterian Weill Cornell Medicine is very experienced in treating patients with AVM both in ruptured and unruptured setting. So patients who have AVM, if they're not treated, need to be followed very closely. Regular follow-up with neurosurgery team is necessary. And we typically do regular imaging studies to make sure that the AVM does not have any change in terms of its angiographic structure. Also, blood pressure management is of critical importance, as you can imagine that if the veins are already being subjected to a higher pressure from the artery due to the presence of this connection, if the patient's blood pressure is naturally high, then this will make the AVM even more dangerous. On the other hand, having an AVM in the brain with no symptoms and if they are being observed, we typically do not ask patients to change their lifestyle. Most normal activities are safe. Most usual exercises such as treadmills, such as jogging, such as bicycling are safe as well. If the patients are engaged in very high intensity contact sports, we usually talk about them individually, and we can discuss on a sort of case-to-case basis. As we mentioned earlier, pregnancy planning is of very important discussion between the patient and the provider. And then also stay up to date with follow-up care with all the imaging, all the hemodynamic parameters. Next slide, please. That's the material I have prepared for everybody tonight. I hope that I was able to give a general overview of what AVMs are, how we diagnose them, and how to treat them. So I welcome any questions.
So I'm gonna go through some of the questions that we had come in before the webinar and some that are in the Q&A. So one of the questions we got before the webinar, as tangled blood vessels accumulate in the brain, how does that accumulation begin to show clinically, as well as including the signs that should alert that medical intervention is needed?
Yes, so because the AVM nidus is present at birth, usually the symptoms develop as the AVM causing more and more hemodynamic stress into the part of the brain where the AVM is present. That is, if the AVM is a high flow AVM, then the area of the brain is deprived of oxygen, is deprived of nutrients, and that can be irritating, can cause seizures, can cause particular headaches related to that particular area. So that's one way of presentation. The other is, as we mentioned, the chronic high venous pressure into these draining veins can cause veins to dilate, can cause veins to bleed, to rupture, and then that's usually how AVM hemorrhage occurs.
Okay, great. And then one of the questions that we got during the presentation, what is the differential diagnosis criteria for AVM versus aneurysm rupture?
Can you say that question one more time?
Yeah.
The
What is
differential diagnosis of,
what is
yeah.
the differential diagnosis criteria for AVM versus aneurysm rupture? Sorry, Dr. Lin, are you able to hear me?
I see. Um, yeah, yes, I understand the questions about AVMs and aneurysms.
Yeah, so
Um,
the differential diagnosis
so
criteria.
yeah, uh, so uh, aneurysms are specifically bubbles outside of a blood vessel wall. These are much more frequent. Approximately 2 to 3% of the population has aneurysms, and as we said, less than 1% of population has AVMs. They are different. They are both blood vessel pathology, but one is more frequent, one is less frequent. Structural wise, AVMs are much more complex, so it involves a abnormal connection between arteries and veins, and is usually congenital, so it's present at birth. Whereas aneurysms structurally is a little bit less complex. It just involves one blood vessel. It's a bubble outside of blood vessel, and it only involves arteries. There's no veins around it. Um, in terms of uh, the type of hemorrhage, AVMs usually cause intraparenchymal hemorrhage. That is, the bleeding is actually into the brain, it's inside of the brain. Whereas aneurysm usually causes subarachnoid hemorrhage. That is, the bleeding is kind of on top of the brain in the leptomeningeal space called the arachnoid layer. So that's called a subarachnoid space.
Great. Thank you for that answer. Another question, do AVMs typically worsen as the patient gets older?
That's a very good question and interesting one. The answer is that we're not entirely sure. Theoretically, as the arterial pressure chronically dissipate onto the veins, they tend to cause something we call hyalinization. They cause something called venous ectasia, so the veins will become dilated, veins will become bigger than usual, and then maybe become weaker on the wall. But that's a theoretical thing. We have frequently also seen patients who, in their 70s or 80s, that with an incidental AVM, that is, they probably lived with this AVM for their entire life and haven't really caused any trouble. But that's also the reason why we say AVMs, although asymptomatic, still need to be followed, because we have seen in a particular AVM change angiographically over time. When we discovered AVM in somebody in their 30s, was asymptomatic. Within 3 to 5 years, it could have an aneurysm associated with it. In 5 to 10 years, the veins could become much bigger, could become much more tortuous. And then those are signs that the AVM is probably going to cause some trouble in the future. So that's when we think that treatment is warranted.
Hmm. Okay, fantastic. And then another question, does perimenopause or menopause or hormonal changes cause AVMs to dissipate? Or I guess if you could just speak about the impact of menopause and hormonal changes on AVMs, that'd be great.
Um, I'm not sure there is clear studies to link the hormonal changes to the AVM. I certainly don't think AVMs will dissipate during or after menopause. The study about AVM rupture risk and pregnancy is not a hormonal relationship, it's more a hemodynamic relationship. Um, so I don't think there is a clear relationship of hormonal status and AVM rupture.
Hmm. And there have been some questions in the chat about AVMs in other parts of the body, specifically the colon. Can similar treatments be used for AVMs in the colon?
Um, that's also a very interesting question. I don't believe all the embolization technology we use for the brain can be utilized in other part of the body, and the radiation certainly not. So radiosurgery is a specific thing for the brain because a very high dose radiation can be delivered very specifically to a small precise part of the brain. I don't think radiosurgery is applied anywhere else in the body. So for AVMs in other parts of the body, probably res surgical resection is a preferred way.
Okay, fantastic. Um, Amazing. I think that is most of the time that we have for questions. I'm dropping in the chat the link to request an appointment with one of our wonderful doctors, like Dr. Lin. Um, and I know Dr. Lin wanted to share a little bit about the rest of the team.
Yes. So um, we at Cornell and Neuropresbyterian Hospital have a very strong, comprehensive neurovascular team led by Dr. Phil Steeg and Dr. Jared Nachman. Myself, Dr. Bodu, and Dr. Schwartz also participate in treating and caring for patients with AVM. So this is very much a team sports. We cover Neuropresbyterian, Weill Cornell Upper East Campus at Queens and in Berkeley Methodist. So you can find us in all three boroughs.
Yes, very exciting. And yeah, thank you all so much for joining. We will be sending out the recording, so make sure to share that with someone else who is interested in brain health or AVMs. And yeah, have an amazing night. We appreciate you coming out.
Thank you very much for hosting, Rebecca.
Thank you. Have a good one. Bye, everyone.